Doctors. So today I'm going to talk a bit about primary biliary cirrhosis. We'll continue with our MRCP cases for the basis. So primary biliary cirrhosis actually is not very uncommon station. In fact, I got this case when I was doing my MRCP examination. So um, we're going to talk briefly about the primary biliary cirrhosis. Now it's known as primary biliary cholangitis. And then as we move forward, I'm going to tell you about all the details about this primary biliary cirrhosis and what questions examiner will ask and what you expect to do in this case. So let's start with our case. So normally in the consultation station, you'll get some scenarios before you enter the room. And in this case, I have selected this scenario. The patient presents to the gastroenterology clinic with complaints of persistent fatigue and severe itching all over her body. She also noticed that her skin has become dry and discolored. So from this, these are certain clues which you should keep in your mind. First of all, the patient presents at gastroenterology clinic. So it means you're going to think all about the gastroenterology cases only. And then the patient has presented with fatigue and there is itching. And the skin has become dry and discolored. So these two are very important points. Patient got fatigue and severe itching. So might be thinking about maybe primary biliary cirrhosis or maybe some other causes. All right, let's see how the case goes. So once you take the history, obviously going to take complete history. You'll ask about in detail about the pruritus, about the fatigue, effect of this on the activities of daily living. I'm going to ask about the social history, family history, and so on. So in this patient, what was important was the patient has hypothyroidism, and this hypothyroidism for past 5 years. But here the patient will say it's well controlled with levothyroxine. However, recently she has developed these new symptoms like fatigue, and it does not improve with rest. And she also mentioned her energy level has decreased significantly, affecting her ability to perform daily activities. So that is very important. If the patient complains of fatigue, tiredness, or any joint pains, anything, you must ask about how it is affecting their activities of daily living, because that is very, very important in the history. Okay, let's move on. So clinical examination, you do the skin examination. The patient's skin appears dry and discolored. There's some evidence scratching and excoriation due to itching. Once you do the abdominal examination, you see patient got mild hepatomegaly, and then you got jaundice. So now, after taking the history and suspicious of you are suspicious of primary biliary cirrhosis, but with the examination, it is clear cut that we are dealing with the some liver problem, because patient got jaundice, got itching, and she is female. So primary biliary cirrhosis will be on the top of the list. Okay, let's move on to a case. So what test going to do? We will like to do liver function test, and we expect the alkaline phosphatase and gamma GT to be significantly elevated. And we all know that there are specific antibodies called anti-mitochondrial antibodies. They will be positive, and maybe some anemia is there. We will like to do the thyroid function test in this case, because the patient goes hypothyroidism, but it's normal, and we did the ultrasound as well, and we show some evidence of cholestasis within the liver. Management, just briefly, the management for primary biliary cirrhosis is ursodeoxycholic acid, and patient is usually started on this as the mainstay of treatment. For itching, we can give some symptomatic relief like antihistamine or topical treatments. We can also use cholestyramine. I'm going to talk it about a bit later. And patient needs a regular follow-up. The patient is advised to undergo regular follow-up appointments to monitor the liver function, disease progression, and the treatment response. Okay, let's talk briefly about the differential diagnosis of primary biliary cirrhosis, because the examiner may ask you about what other things you are thinking about. So primary sclerosing cholangitis. Primary sclerosing cholangitis, we know that is another chronic liver disease, and it involves inflammation and scarring of the bile ducts. So it can lead to similar symptoms like fatigue and pruritus and jaundice, but imaging and liver function can help differentiate primary sclerosing cholangitis from primary biliary cirrhosis. What else? Autoimmune hepatitis. Well, this is an autoimmune liver disease that can have overlapping features with primary biliary cirrhosis, and both conditions can cause over elevated liver enzymes, and they may coexist in some cases, so leading to overlap syndrome. Hepatitis B and C infection, they can also cause hepatomegaly, they can also cause elevated liver enzymes and jaundice, but obviously we're looking at the serological testing for hepatitis B, and hepatitis C antibodies can help rule out these infections. Drug-induced certain medications and toxins can also lead to liver damage, and it will elevate liver enzymes. So obviously a thorough medical examination and obviously the drug history is very important. Alcohol liver disease, well, chronic excess alcohol can lead to liver damage, so it can result in hepatomegaly, and we may have elevated liver enzymes. So completing our list of the differential diagnosis may be non-alcoholic fatty liver disease or non-alcoholic steatohepatitis. It involves the accumulation of fat in the liver, and it can cause liver function abnormalities. Imaging and clinical history are important. Biliary obstruction, other conditions that obstruct the bile ducts like gallstones and tumors also can lead to similar symptoms to primary biliary cirrhosis, including jaundice and itching. Wilson's disease, well, this is a genetic disorder. It can lead to copper accumulation in the liver and other organs, resulting in hepatomegaly and hepatic dysfunction. Hemochromatosis is another disorder. It's characterized by excess iron absorption and accumulation in the liver. It can also lead to hepatomegaly and elevated liver enzymes. And finally, infiltrative liver disease. So conditions like amyloidosis or sarcoidosis, they can affect the liver and lead to hepatomegaly and abdominal liver function. So I put this complete list of differential diagnosis. So if you manage to remember 3 or 4 differential, that would be enough. So what does the NICE guidelines says about the primary biliary cholangitis or primary biliary cirrhosis? So diagnosis and initial assessment. So NICE usually recommends diagnosing primary biliary cirrhosis based on the clinical features, so and positive AMA and characteristic histology. Liver biopsy may be considered in some selected cases. Assessment, well, it should include liver function tests, AMA testing, and screening for complications like osteoporosis and vitamin deficiencies. So this is we talking about the NICE guideline. It's good actually when you are in the examination and you give some reference like according to the NICE guideline, the patient diagnosis and initial assessment like this, management is like this. So management of early primary biliary cirrhosis according to NICE guidelines, still we already discussed ursodeoxycholic acid. This is the first line treatment, and it recommends, NICE recommends to give to all patients with primary biliary cirrhosis unless it's contraindicated. Regular monitoring obviously of liver function and symptomatic assessment is recommended to assess the treatment response. So NICE recommend assessing treatment response at 12 months after starting the ursodeoxycholic acid, and referral to a specialist should be considered if elevated alkaline phosphatase or it remains elevated, then we consider referral to the specialist. Some of the complications which are related to primary biliary cirrhosis like osteoporosis, NICE provide guidance on assessing bone health and considering the bisphosphonates for osteoporosis prevention and treatment. And then obviously there is some vitamin deficiencies like screening and management of like this vitamin fat soluble vitamins deficiencies are recommended. So this is about the NICE guideline. I hope that you will remember it. You must have read it a few times already. Second line therapies. Now for patients who do not respond adequately to ursodeoxycholic acid, NICE suggests considering second line therapies like obeticholic acid in specific circumstances. I'll talk about this a bit later. Liver transplantation. NICE provides recommendation for assessing patient for liver transplantation and post-transplant care. NICE guidance on managing pruritus primarily include the use of bile acid sequestrants and other treatment options. So this one we'll talk later. And patient information and support. NICE obviously emphasize the importance of providing patient with accurate information and support regarding their condition, treatment, and potential outcomes. So this is what the NICE guidelines say about the primary biliary cirrhosis. Now, examiner, when you mention this, because there is not much there, maybe they will ask you about, can you tell me a bit more about ursodeoxycholic acid? So I'll just briefly mention the mode of action because sometimes they will ask. So remember that ursodeoxycholic acid it has a unique structure and it differs from other bile acids. It actually competes with more toxic bile acids such as hydrophobic bile acids for transport into hepatocytes. This results in alteration of bile acid composition in the liver and bile, potentially reducing the toxic effect of the more hydrophobic bile acids. So remember this mode of action because this is the main mode of action, that it competes with more toxic bile acids. There's some say that there's some bile flow improvement, so it can increase the flow of bile by making it less viscous and so reducing the surface tension of the bile. And this can help prevent bile stasis and cholestasis, which are common in liver disease like primary biliary cirrhosis. Ursodeoxycholic acid also has an immunomodulatory properties that may help dampen the autoimmune response in conditions like primary biliary cirrhosis. And it is thought to affect the immune cell function and reduces inflammation in the liver. It has got some hepatoprotective effect. It has protective effect on liver cells by reducing the oxidative stress and inhibiting the apoptosis and promoting the survival of hepatocytes. Cholesterol solubilization, it can help solubilize cholesterol in bile. It's very important in the prevention of the cholesterol gallstones. So these are all the main mode of action of the ursodeoxycholic acid. There are some other also like anti-inflammatory effect. It has shown to inhibit certain pro-inflammatory cytokines and signaling pathway, contributing to the potential anti-inflammatory effect in liver. And anti-fibrotic, it has got anti-fibrotic properties as well. In some studies, it has demonstrated anti-fibrotic effect, which can be beneficial in preventing the progression of fibrosis and cirrhosis in liver disease. So I mentioned almost all mode of action, so just try to remember maybe 2 or 3. That should be okay. But remember that the first one, the effect on the bile acid composition, because ursodeoxycholic acid actually competes with more toxic bile acids. This is the most important mode of action which you should remember. So also you can say finally that it's important that exact mechanism by which ursodeoxycholic acid exerts its therapeutic effect, these are still being studied. and its mode of action vary depending on specific condition being treated. Usually they will not ask about the dosage, but it's a good idea to have some idea about the dosage, because you can volunteer this information and it will create a very good impression on the examiner that you have treated a patient with primary biliary cirrhosis. So the typical starting dose for sodium acid in the treatment of biliary cirrhosis is around 13 to 15 milligram per kg per day. And this is usually divided into 2 or 3 doses and it's taken with meal. What about the maximum dose? The maximum recommended dose is often around 20 to 25 milligram per kg per day, but higher doses may be used in certain cases under the guidance of obviously the gastroenterologist. Dosing adjustment may be made based on the patient response to treatment and any potential side effects. So this is all about the ursodeoxycholic acid. Try to remember few mode of actions. Examiner will ask you about this ursodeoxycholic acid, because you know this MRCP examiner sometimes they ask some a bit more detail, because we have plenty of time, especially if you're doing the consultation session. There's a lot of time there for the examiner to ask you questions. So what about the pruritus treatment in primary biliary cirrhosis? The pruritus is a common symptom in patients with primary biliary cholangitis, and obviously it specifically impact a patient quality of life. Understanding is not fully understood, but there are several approaches to managing and alleviating these symptoms. So treatment options include bile acid sequestrants. So bile acid sequestrants like cholestyramine or other is cholecystyrene. These are commonly used to manage pruritus in primary biliary cirrhosis. Now, these medications actually bind to bile acids in the intestine and preventing their reabsorption and promoting their elimination in the stool. So, by reducing the bile acid level, the bile acid mediated itching may be relieved, and these medications usually are taken orally and may be effective in some patients. What are the other options for the pruritus? Rifampicin, which is an antibiotic, we all know it very well because we use it for management of the tuberculosis. So it has been found to have anti-itching properties in primary biliary cirrhosis, and is thought to affect the metabolism of the bile acids and possibly other mechanisms that contribute to pruritus. However, remember, its use requires careful monitoring due to potential for drug interactions and side effects. Another option for the pruritus is opiate antagonists, and medications like naltrexone or naloxone. These are actually opiate antagonists, and these have been used to alleviate the itching. They work by affecting the opiate receptors that may be involved in itch transmission. And these mediators may be considered for patients who do not respond to other treatment. Antihistamine, while antihistamine may not directly target the underlying cause of pruritus in primary biliary cirrhosis, but they can help reduce itching by blocking histamine, a substance we know that play a role in the itch response. Okay, what other options we have? Well, sometimes we can use the SSRI, and like sertraline, these have been used to manage pruritus in primary biliary cirrhosis. The mechanism of action we don't know, but they may help moderate a serotonin level, which can impact its itch perception. Then there are other options like topical treatments, topical cream, lotions or ointment containing emollients or methanol can provide temporary relief from itching and soothe the skin, and they can be applied directly to the affected area. What about phototherapy? In some cases, UVB, ultraviolet B phototherapy may be used to manage pruritus, and it involves exposing the skin to controlled amounts of UVB lights to alleviate the itching. And finally, lifestyle modifications, maintaining good skin hygiene, avoiding hot showers, wearing loose fitted clothing, and using fragrance free moisturizers. These all can help minimize the skin infection and itching. So, as you can see, there are quite a number of treatments for the itching in primary biliary cirrhosis. So, try to remember all of them. If it's difficult to remember all of them, at least 4 or 5. So I'm going to talk about the OCA. It's a synthetic bile acids analog that works by targeting specific receptors involved in bile acids metabolism and liver functions. So indication, it is indicated for treatment of adults with primary biliary cholangitis who have an inadequate response or they are intolerant of the ursodeoxycholic acid. And it is intended for use in patients with compensated liver disease. The dosing actually it vary based on the patient individual characteristics, liver function and treatment response. However, there are some general dosing guidelines. Usually starting dose is around 5 milligram once daily, and then we titrate after 3 months of treatment. It should be increased to 10 milligram once daily. If the patient response is inadequate, defined by the specific biomarker criteria. So we start with the 5 milligram, and after 3 months we can increase it to 10 milligram. And this is the maximum dose actually, not more than 10 milligram once daily. So let's move to our case presentation. How are you going to present the case? Now you've done the history, you've done the examination. So after that, obviously you're going to present your case, especially if you are in the consultation station. So briefly, this patient, a 45-year-old female teacher, presents with complaining of persistent fatigue and itching. She reports that the itching has been ongoing for several months and is particularly bothersome, affecting her daily life and sleep. The patient has a history of hypothyroidism, which is managed with levothyroxine. She also mentions occasional discomfort in the right upper side of her abdomen. On the clinical examination, upon examination, the patient's skin appears dry, discolored, and there is evidence of scratching and excoriation due to severe itching. Abdominal examination, notice mild hepatomegaly, Murphy's sign is negative, and jaundice, notice scleral icterosis involved is observed. So once you present your case and you are given a brief history and your clinical examination findings, remember that it is always better to just carry on until the examiner stops you. So you will carry on by doing, I would like to do some investigations. I want to do the liver function test, alkaline phosphatase and gamma GT will be elevated. I expect them to be elevated in this case. I like to do serology with anti-mitochondrial antibodies, which is consistent with diagnosis of primary biliary cholangitis. And finally, I like to do some imaging like abdominal ultrasound, and most likely it will reveal the cholestatic changes in the liver. So suppose if this case is in your abdominal station, so there will be a scenario written outside. So this scenario will be something like this. This patient is a 52-year-old female office manager who reports occasional discomfort in the upper right side of the abdomen and persistent fatigue. She denies any significant weight loss or change in the bowel habits. So they are giving you a clue that malignancy is less likely because she don't have any weight loss. So obviously if there's a short case, or we call it the abdominal station, then you'll be more focused on the abdominal examination and general examination rather than more focusing on the respiratory system, the CNS or the CVS. So If you are in the short case, you just have to do the clinical examination. On inspection, no jaundice is observed. There is mild icterus. Palpation, mild hepatomegaly is noted, and the liver edge is palpable below the costal margin. You're going to do the percussion, no shifting of fluid, no shifting dullness or fluid wave is appreciated. Auscultation, bowel sounds are normal. And the skin examination, patient's skin appears dry and discolored, particularly over her extremities, and multiple areas of excoriations are visible, especially on the arms and legs. So here you can see the um, scratch marks here, and these are excoriation marks. Remember, if you see these type of um, scratch marks, which is very significant of severe itching, then remember that if you are in abdominal station, then primary biliary cholangitis, you should be thinking about it. It should be on the top of your list. If you are in the um, consultation station, still it is very important, but obviously you have to do more thorough history and more thorough examination. Here is another example of some scratch marks which are present at the back. So that's all about the primary biliary cirrhosis or primary biliary cholangitis. So I've given you almost everything here. I don't think so examiner will ask any other questions. Remember, be confident, remember your differential diagnosis, at least 3 or 4 differential diagnoses. Whatever you're saying, you have to back it up. If you say I want to do ursodeoxycholic acid, examiner will ask you about the mode of action. Dosing they will not ask, but if you can mention the dosing also, they will be impressed. So just remember that in any case, not in this case, any case, remember the differential diagnosis and remember the relevant history and examination. Okay. Hopefully this will help you in your preparation. I'll see you in my next video, which most likely I'm going to do soon, and we're going to continue with our MRCP PACES cases preparation. Okay, thank you very much, and